afternoon, all. I have only a few brief comments to make. I think I've spoken to most of you already today, at least once. And I don't have much to add to the statement that was released earlier today from our hospital president, Amy Brewer. If those of you who haven't seen or have a copy of our statement, I have some available to you if you wish to chat with me after.
Is there any way you just keep the papers further to the mic?
Thank you.
Thank you, sir.
I do want to emphasize and clarify some of the reporting that's out there. Both of our hospitals are open, operating safely, and accepting patients in our emergency departments and our clinics throughout the community. We continue to deliver the kind of care that people have come to expect of us over our 60-year history here in Solano County. For a few hours last night and in the early morning hours, we did ask the EMS administrators to redirect some ambulance traffic to neighboring hospitals while we adjusted our staffing after some of our employees were taken off their work schedules and sent home to monitor their situation and their current health. We continue to check and double check to ensure that we've identified every employee who has come into contact with a patient, no matter how briefly, after the diagnosis. As far as the head count is concerned, at this time I can say it's a moving target. We have identified dozens of our employees and our health team, but it still remains less than 100. I want to also ask, implore you to consider the patient privacy. I know you're doing your best to report on all facets of this story. Some of our employees, however, are being contacted as they leave work, somehow contacted through their private emails and their cell phones. And please respect their right to privacy as well. Finally, again, I will add that we're pleased to be able to work with our partners in County Public Health, the State Department of Public Health, and our other neighboring hospitals, as well as the experts from the Centers for Disease Control. Again, if you need to see our full prepared statement, I have copies for you afterwards. Thank you.
Next, I'd like to introduce brief remarks introduce the CPH, who is the acting state epidemiologist, James Watt. Good afternoon. Thank you very much. I don't have any prepared comments, but I did want to say that I am here representing a team of technical experts who are here to support efforts by Solano County to respond to this event. And, Dr. Matias outlined a number of steps that are being taken, and we are actively working with them to get those things done and get them done. Appreciate it. And then finally, I wanted to introduce Christopher Braden, representing the CDC. Is it friendly there? Yeah.
Thank you very much, Dr. Matias. Yes, my name is Chris Braden. I'm from the Centers for Disease Control and Prevention. I flew in from Atlanta, Georgia this morning. I'm here at the invitation of the county and the state, also to provide technical expertise to the various investigations that are going to be going on around this case. And, in these hospitals where we know that the patient has been cared for. So that's our role. We're going to be basically embedding within the teams that are going to be doing these investigations, both on the part of the state and the part of the counties.
I guess it's time for questions.
Doctor, is it possible that this is more than just a coincidence that this first U.S. case of communicable contraction of this virus came in the same area where this Travis Air Force Base mission was?
You know, I think it's probably more of a coincidence, not in the sense that the evacuees had anything to do with it, as much as it is that our providers are just way more aware and astute because of it. You know, I would offer to you that there are probably cases of coronavirus from community acquisition in multiple parts of the country right now, and they didn't necessarily have the experience to know what to look for. So I would go the other way with that, and I would say we see it as a blessing that we had the opportunity to prepare.
How long do these healthcare workers
switching from containment to mitigation?
Yeah, so containment, thank you, that's a question. So containment represents the goal of preventing the disease from entering into your space at all. You try to keep it controlled in a location where it starts and bottle it up so it can't go anywhere. And that's only possible when you're dealing with a disease condition where you know everyone who's sick and they get sick before they spread and you can contain them. And that's a rare reality. Mitigation is, we know that the cat's out of the bag in terms of it having spread. And what we're trying to do is slow the spread as much as possible. The slower that it spreads, the more time we have to identify treatments that can help, the more time we have to consider the possibility of a vaccine and other types of measures to protect. So mitigation is extremely important in slowing the spread of a disease, but it's also a recognition that it's not staying in Wuhan. And we already know that. There are multiple outbreaks throughout the world.
Doctor, how long will those healthcare workers be
Quarantined.
self-quarantined, and could those numbers rise significantly further than the dozens?
No, the numbers won't rise beyond the numbers that have already been identified because everybody has been evaluated. We're still in the process now, but we know who all the healthcare providers were that could have been in that environment, so that's been very thorough. And they started as soon as we were aware of this case and worked through the night. And we have a very good handle on that, so the numbers won't rise. And the length of time for isolation and quarantine, so isolation is if you already have symptoms. And we're testing everybody with symptoms to see if they have those symptoms from coronavirus. If they come back negative, we still assume that they could develop coronavirus in the 14-day incubation period. So 14 days from last exposure to the patient. Now the good news is that for many of those healthcare workers, we're already 7 days in, because people that only saw the patient in the emergency room, for example, did not see the patient on the floor. And then that patient wasn't in our county for a number of days before diagnosis was made. The patient had already been transferred to UC Davis. And so our personnel only need to be in there for 14 days from the time of last exposure.
And when was she last here?
I'm sorry.
When was she last in Solano County?
3 to 4 days ago? What was the 19th?
Morning of the 19th.
Morning of the 19th was the day of transfer.
Doctor, some countries.
Whistleblower complaint. There's a whistleblower complaint that federal health workers were really moving in and out of Travis Air Force based on quarantine and possibly, without training or protective gear. Is there concern there? And I would also like Mr. Braden to answer if possible.
Well, so I don't have anything to say about a whistleblower complaint. What I can say is that we've been working with our federal partners on the base since they first arrived. And I have actually never worked with a more meticulous group of people. I mean, they were scary individuals. And so the likelihood that would happen is low to begin with, but it would also have no explanation whatsoever for this patient, because this is a random individual in a community of 450,000 people.
Doctor, some folks.
So yes, we are aware of a whistleblower complaint, and what I would say is that, as we have said many times, this is a rapidly evolving situation, and we learn more and more all the time. And the situation actually on March Air Reserve Base, where that complaint was lodged, was quite different. And we know that there was no either evacuees with coronavirus in that group, nor was there any transmission around. So those are the things that we can say. And I'd just like to say, again, repeating here for Travis Air Force Base, that there's no indication that any of the evacuees, when having coronavirus disease, would have crossed paths with this case of disease.
So, I'm curious, it's clear that this person did not meet the criteria.
Correct?
Initially. So is that criteria now changing? Like, are you retiring that to now test people who may not have even come in contact with this person?
So there's a couple of questions in there. Yes, the criteria are changing. I think Chris is probably best able to answer that. As for what we can and can't test, there are two problems. One, what are the criteria? And two, what are the number of people that they need testing relative to the ability to test? I mean, we're still dealing with a test that is limited in its availability, so we still have to prioritize by risk. And we're not going to be prioritizing maybes over likelies.
Why is it so limited in its availability? I mean, there's other countries that have this test widely available.
So, first thing about testing and testing of this particular individual. Like I said, rapidly evolving situation. In just when you talk about testing, it's not just a healthcare provider in CDC. There's a number of people that are involved in that decision making. There's the people at the hospital, of course, and the providers, also local health department staff get involved in making those decisions and determinations about who should be tested, who may not need to be tested. State health department may become involved, and then eventually we have a consultation line that's open 24/7 that takes those consultations to determine who should be tested.
This case took 4 days for someone to make a decision.
Yeah, so what I can say is that there were multiple people involved in the decision over those four days. It wasn't necessarily CDC. And the other thing is there was a change in the approach about who we test during that period of time, so that the people with more severe disease met the definition of those who would require testing. And that change and that kind of policy did take place during that time.
Doctor, could you talk about how you're investigating the female patient and who she came in contact with and how you're going about that?
Let me also amplify a little bit about what Chris is suggesting. Patients like the one who ended up being positive are huge in number in our hospital. This was a needle in a haystack. And so there's no way to determine if it would be that versus anybody else like that. And that jump in number of people to test, we're just not prepared to do. But the likelihood is still incredibly low compared to the people with exposure to known cases, people who have traveled from China. So the cases among them are far higher in proportion, so we still have to prioritize them until there are more resources. As for what we're doing in the investigation, we have identified family members of this individual, and they are in isolation pending testing. They'll remain in quarantine for this 14 days since last exposure to the patient. The patient's workplace has been fully addressed as well, and we are identifying any potential interactions with people that are not employees in the workplace during the time that the person was infectious. The good news in the community is that the individual is really only potentially infectious for about a 3-day window before hospitalization occurs. And so we have a narrow enough window to work with that we can be very aggressive in identifying all of the possible contacts in the community. And those are individuals who will be assessed and will be isolated or quarantined as appropriate.
There are some people that want to know where this victim was.
There are a lot of people want to know a lot of details about the victim that I cannot divulge. What I can tell you is good news and bad news. Bad news I can't tell you. Good news, it doesn't matter that I can't tell you because if it's community acquired, the risk is not at the location.
There was some pushback and back and forth between the state and CDC today on how quickly the CDC moved because the state only on Sunday. Can you get into that at all as far as whether the testing was appropriate and whether it should more quickly?
So the consultation came to us on Sunday the 23rd to determine whether the patient should be tested.
Sure. Do you think Congress or the White House has been slow in reacting with funding for this? You got a president who said that April we're all going to go because it's going to be warmer. They're just now talking about extra funding to handle this. Has it been slow in Washington?
Well, so a couple of answers to that. Number one is that, we do this type of work day in and day out. And so a lot of what we get in our annual appropriations funds this type of work. Now, given that this is a much bigger type of circumstance, like we had with H1N1 flu or with SARS or for that matter Ebola, so forth, you do need supplemental funds in order to be able to handle that. Now, exactly how much funding we're going to be able to need or how much we actually do need is a bit difficult to determine at this point. But I trust the Congress to come up with a funding amount that will at least make us able to not only support ourselves but the states and what they need to do.
The governor's press conference this morning, he mentioned test kits will increase exponentially, but also left the kind of closed with the issue of the mask. California has a million of masks.
Well, let me just, this is the third time I've been asked about the tests, and let me just address this a bit. So, number one is the test has actually been developed very quickly in many countries around the world with just what was some public data from the sequence of the virus that was put out by China early on. And so we are actually, around the world, able to test much faster than we have in the past with the technologies that we have today. Now, we have been frustrated in getting out a test widely that's being able to, that was manufactured at CDC because we're very, very careful about the quality assurance of that test, and some of the laboratories have seen some issues with quality assurance that we're addressing. Now, in addition to that, we would really like to see some commercial tests come out to be able to provide that to public health laboratories and to hospital laboratories. And I believe that commercial entities are working with the FDA to make that happen as soon as possible.
So everybody that came into contact with this new patient, healthcare workers, family, co-workers, what are they being asked to do? And all those three groups combined, what is that number at? How many people?
So they're all being asked, depending on whether they have symptoms or no symptoms. If they have symptoms, we are testing them and asking them to home isolate while we await results. If they have no symptoms, we're asking them to home quarantine. We are interacting with every one of those individuals multiple times daily to make sure that their needs are met, to make sure that they aren't developing signs or symptoms of the disease. So there is an ongoing active surveillance of that group of people. As for the total number, because we don't yet know how all the North Bay health professionals are going to end up on this, it's under 100, and it involves multiple counties.
Can I ask you, doctor, because you don't know how, maybe because it's so, I don't think so, because you don't know how this person was exposed and acquired it, how do you go about, other than what you just described with people who you do know came into contact with this person, how do you go about, now that the cat's out of the bag, mitigating the spread when you don't know where they are?
So, it's an excellent question. And the thing about this disease is that it's too early to know what path it's going to take in its natural course. SARS came on with a bang and then went away. MERS has existed in its location and occasionally jumps out and causes international spread, but then retreats to its location. H1N1 came out with a bang and was the predominant flu strain for many years. So we can't know today what picture we're going to deal with. What we do know is that if we can remind our community to practice proper droplet precautions, as they should be anyway for flu, that will slow the spread and will optimally protect people from spreading to others. Now, obviously, that's very difficult in families. I mean, interactions within families pretty much guarantee that there will be intra-family spread if this disease becomes more widespread. Our hope is to prevent outbreaks in healthcare institutions, in schools, in congregate facilities. Our goal is to have it be a low level of disease in our background where most cases are mild and don't require hospitalization, and delay it enough so that those who are severe enough to need hospitalization will have something that we can offer them in the way of treatment.
What's the difference between home isolation and home quarantine, and is there a legal mandate behind either?
So the difference between isolation and quarantine is that when a person has symptoms, we isolate them. We isolate them in a much more rigorous way than when we quarantine people who don't have symptoms. Because we were waiting for the results to come back on that person with the symptoms as to whether or not they have this disease or don't. So quarantine can, for example, permit people within a family to interact on a limited basis, wearing proper PPE, for example, but isolation would not. Isolation is just a much more strict level of containing a person we're worried about and keeping them away from others. And so the answer really has to do with what else do we do with it, and it's the testing that's the most important. With quarantine, we're waiting to see if symptoms emerge, so we check on you frequently. With symptomatic disease, we're worried that you might get sick enough to need hospitalization, so we're prepared to do transport, etc. So it's a somewhat more aggressive stance that we have to take.
You touched on this earlier, that this case of community spread is a coincidence that it's in this county.
One sec, I'm sorry.
Are there any legal penalties? We see Sheriff's Department members here. Are they going to get in trouble if they leave?
So I can issue isolation and quarantine orders. You probably have no reason to know this, but we deal with this issue all the time with tuberculosis, with measles, with chickenpox, and there's a lot of disease conditions where we have to isolate and quarantine people. So our ability to do it is very well practiced, and we do it with great frequency. It is very, very rare that people are not complained, because the risk to themselves, to their families, to others is recognized by most people as being genuine. So yes, we have the authority if we need it, and we rarely have to exercise it because most of the people we deal with are actually very compliant. As to the issue of coincidence, I don't think it's coincidence. I think it was a better ability to identify on the part of our community. I genuinely believe that our practice, if you will, in dealing with the couple of dozen evacuees that are positive for coronavirus has heightened our awareness of what to look for and how to handle it. And so I'm not suggesting that there aren't incredibly good and astute physicians all over the country. I'm just saying we're blessed to have a lot of good ones here in our county, and I think that if it's a coincidence, it's because they were able to do it quickly.
There's also part of the whistleblower complaint, though, is that DHS staff that say they were not properly prepared, trained, had protocols, were out in the community.
You're trying to draw a link to the evacuees. I can tell you that the statistical likelihood, if everybody on base were doing a horrible job and were wandering our community, they never would have encountered this person. So there's just no logical way to draw that conclusion. We have time for a couple more questions.
Can you confirm that this patient is in serious condition? Because the congressman said it on the air, and I just want to confirm that that is true.
I honestly can't confirm it because the patient's at UC Davis, and once they left our county, I ceased to have a legal right to keep track of their health status. So I honestly don't know.
Okay, and then a question for Dr. Braden, just because I first spoke to you at the March Air Reserve Base.
Yes.
In that time, since that first plane landed to where we are now, is there something, is there a few really important nugget that the CDC has learned in that time that you don't feel like people are really understanding about coronavirus right now?
Well, I would say that there is a major shift in communication to communities that's occurred during this time. And it has to do with what we're really seeing right now and what Dr. Matias is talking about. It's really a shift from detect and contain to really a mitigation strategy. And we still are doing those types of things that are trying to contain it as long as possible. We are still screening people coming from China in the airports. We are still trying to identify any types of illnesses in the repatriated individuals and so forth. But while we do that, we as a country, as our communities, do need to start to prepare for the fact that we're going to see community transmission in the United States. And I think this is probably one of the first cases where, where we picked it up. It may be other places and we don't know it. So that's the shift that we all need to take, is to say, we're going to keep it over there, to we've got to prepare for what we're going to do to protect ourselves when it's here.
What has changed? What has changed with
This is the last question.
There are now college students at least 3 campuses that they have come into contact with COVID-19. In the event that one of them tests positive, what will the CDC do, given that there's such a high concentration of individuals at a campus in terms of mitigation?
Yeah, so it will vary from campus to campus and from individual situation. So sometimes if there is widespread contact with an individual who is ill and we know may have been transmitting, why that situation may take more drastic measures about what you would have to do in a particular institution versus somebody who may have been there overnight and just exposed a few. You may not need to take more community-wide measures. So it really depends on the situation.
If it was in a dorm room?
Well, then you would determine, look closely at those particular roommates, who else might have been there. It's the contact investigation that we would usually do to determine what more might need to be done for the institution as a whole.
It seems like a simple thing.
Thank you all.
All right, thanks everybody. Thank you everybody for your time. Really appreciate it.